to go ahead and get us started. I'm going to introduce our moderator, who is Dr. LaShonda Spencer. Dr. LaShonda Spencer is an MPI at UCLA-CDU CFAR, professor of pediatrics at Charles Drew University, and the director of Oasis Clinic. Dr. LaShonda Spencer will go ahead and introduce our speaker once it's time. Dr. LaShonda?
Thank you very much, Dami. Welcome everyone to the UCLA CDU CHIPTS CFAR and Grand Rounds. So I'd like to introduce Dr. Ricky Bluthenthal. He is the Associate Dean for Social Justice and Vice Chair for Diversity, Equity, and Inclusion, and a professor in the Department of Population and Public Health Sciences and the Institute for Prevention Research in the Keck School of Medicine at USC. He received a BA in History and Sociology from UC Santa Cruz and a master's and PhD in Sociology from UC Berkeley. His research has established the effectiveness of syringe exchange programs, tested novel interventions and strategies to reduce HIV risk, and improve HIV testing among injection drug users and men who have sex with men. He has documented how community conditions contribute to health disparities and examined health policy implementation. His current studies include an observational cohort study of how cannabis legalization impacts use patterns and health outcomes of cannabis and opioids among people who inject drugs, and a randomized controlled trial to test the efficacy of a single session intervention to reduce injection initiation risk behaviors among established people who inject drugs. Dr. Bluthenthal has authored and co-authored over 180 articles in peer-reviewed scientific journals such as the American Journal of Public Health, Social Science and Medicine, The Lancet, among others. He is on the editorial boards of the International Journal of Drug Policy, Drug and Alcohol Dependence, and is an associate editor of the addiction section of the Annals of Medicine. Welcome, Dr. Bluthenthal.
Thank you for that warm introduction and for the invitation to share some research that we've been working on here at USC in my community-based studies with people who inject drugs. So glad to be here. So let's just get started. What I'm going to be talking about is, I guess, what we're calling social immiseration, and then a little bit on changing drug use patterns that we're sort of in the field and able to observe now and look at those in relationship to HIV. The data I'll be presenting will mostly be from Los Angeles and Colorado, but there'll also be data from other studies in other locations. Here's my funding disclosures. And then I just want to acknowledge, usually I put this at the end and then don't say anything about it, but I've been very fortunate to have terrific students and friends and co-investigators over the years, none more importantly than Alex H. Kroll. And then I've had some terrific doctoral students in process and recently finished. So let me just shout out Kelsey Simpson, who's now doing a postdoc at UC San Diego, and Jesse Goldshire, who will be finishing here shortly. So look out for those names in the future. I've also been able to work with a lot of community-based organizations over the years, mostly CHPLA in Los Angeles and the Homeless Healthcare Los Angeles. And then for this Denver study, we had a great collaboration with the Harm Reduction Center in Denver. Okay, so I'm going to, sort of following the tip that public health has now discovered social determinants of health, sort of drill down a little bit on what we're calling social immiseration and how that contributes to HIV risk among people who inject drugs. And then, and so that work is more or less finished. I mean, we just have to write it up and submit that for publication. The other stuff I'll be talking about, which is the sort of these changing drug use patterns, is more preliminary. So, and I'm not quite sure what to make of all that, but I'll share with you what I sort of think is going on at the moment. I'd be interested to hear what you think about it or what you're seeing. And then I'll just talk about what are some of the solutions that we have at our disposal or that we need to implement if we want it to be successful at preventing new HIV outbreaks among people who inject drugs or people who use drugs. All right, so let me just start with the sort of what's been happening recently, but let me do that in reference to my history. So I've been doing these studies since 1990, which makes me old. And, the great advantage of that, aside from the fact that I've managed to stay alive, is that, we've really seen big changes and successes at preventing HIV among people who inject drugs. It's in some places in the communities I worked in Oakland and Richmond, California, and East Palo Alto, we had 20-30% of people being HIV infected in the early 90s. So that's no longer the case. In a place like Los Angeles, there are very few people who become HIV infected through injection drug use. But that has not been the whole story. And so there have been, a couple of reports, and of course, the Scotts County outbreak that happened in 2015-16, where about 200 people became HIV infected in an 18-month period in a rural Indiana county. That's not listed on here, but that was sort of got everyone's attention because it was so unlikely. But of course, it was completely predictable in that you had these sort of changes going on with misuse of prescription drugs and no prevention services. So it's important to realize that in his genius, the governor of Indiana, who I believe at the time was Pence, closed down Planned Parenthood, which had been one of the few places that was actually doing HIV testing in Indiana on a consistent basis. And so you had these 200 cases. And just to give you an idea of how bad that was, during that same period in Los Angeles County, which has, 13-14 million people, we had 50 cases, right, of new cases of people getting HIV. So this sort of Scott County thing, homelessness, sex work, has been popping up now in all these other places, and this sort of Lice paper is a nice summary of the different stories that have been going on, including things happening in suburban Massachusetts, urban areas like Philadelphia, but then also novel places like Northern Kentucky and Caleb County, West Virginia. So, we're going in the wrong direction in some respects. And the truth is, because we don't do widespread HIV testing among this population the way we used to, we're very vulnerable to new outbreaks happening without us being sort of aware of it. So just to reemphasize this point about the role of homelessness, there was a great meta-analysis published in the Lancet recently looking at HIV and hepatitis C, and sort of the main take home from that was that being unhoused, unstably housed, basically doubled your chances of getting HIV. And then in a modeling study that looked at various different countries based on income level, again, we see a strong relationship between being unhoused and people becoming HIV infected. I think their estimate was around 17%. It was higher for 17% higher for people who were unhoused in high income countries. So this is a sort of continuing issue, and as we know, because of economic inequality, a place like Los Angeles, homelessness continues to grow, and it will happen in other places as well. All right, so I'm using the term social misery, and I guess I use the term misery because I've been able, particularly in the last year and a half, to be in the field more, and I just, as a human, want to share that the conditions that people find themselves living in are appalling. They're not conditions that are going to facilitate people being able to take care of themselves. And they're actually the function of choices that we make as a society. So they're not bad people, they're unfortunate people. And the policies that we implement in many respects, in some respects, important respects, really are part of the problem, aside from the fact that we're not dealing with sort of the structural issues around why people aren't housed. In fact, Ben Hinwood has a recent paper out with some co-authors. He's the second author, but if you look up his name, you'll find it. And basically, they looked at sort of different explanations for homelessness in the United States, and income inequality was the main one. So people aren't making enough money to afford the market level rents, and then we're not building alternatives to the market that ensure that people can stay housed. All right, so I'm going to be basically referring to data from 3 of my studies. So one was a mixed method study that we conducted and ended in 2013. And then we did this cohort study looking at injection initiation in 2016 and 18. And then I'll present our current data, really just using the data from 2021 to 2022. So we were able to get back in the field, and after stopping the study for a year, basically in April 2021, and then we collected baseline data through November 2022. So that's the data I'll be sharing. And I'm sorry, that's wrong. We have 429 people in that study for study 3, not 309. Sorry for not updating that. Okay, and then there's just sort of the overview of the study. So the last 2 studies have been cohorts, and the previous one from the early 2011 was a cross-sectional study. All right, so the way my group of people have been thinking about unhoused folks is within this sort of ontological security framework. And, basically the point that this framework makes is that for people to sort of be healthy, they need to have constancy in their social and material environment and reliable social relations. And with that in mind, if we have policies that are persistently and consistently disrupting both physical and social security, you will end up with people unable to achieve well-being, as Stonehouse made in his study on homelessness. So what we've done is we've looked at the association between being unhoused and displaced. And by displaced, we mean, so you're in an encampment and then you have to move for some reason. And we've looked at that specifically with those people, and you'll see from the data that we present. We've also used this measure subsistence that was sort of developed by Gelberg and colleagues a while ago to look at whether people are getting their basic needs met, which sort of relates to, again, that ontological security framework. Okay, so the story here is basically I've been doing these sort of community drug use epidemiological studies for 30 years. And then my population in more recent years have become increasingly unhoused. And so this is sort of data from multiple studies looking at where we're at. In the current study, about I think it's 75 to 80% of folks are unhoused. And you can just see some neighborhoods in LA. And basically the story is homelessness has increased in most of them, with the exception of Skid Row, which was already very high. And people haven't really been looking at this closely, unfortunately. I mean, there is some good stuff that the group at Chicago published, Mackie Aminti, Mary Ellen, and her group, just looking at trends in homelessness, and they found that it's also increased there. Also, Dennis Fisher actually has done a lot of work in Long Beach on homelessness down there. So if you're interested in that, I'd look to Dennis Fisher's work as well. So this is a study we published where we first began looking at this, the impact of relocation and displacement. So this is data from our study in 2016 to 2018 in San Francisco and Los Angeles. And the key take home here is basically people having to move in the last 30 days was significantly associated with a wide range of health outcomes. So it increased non-fatal overdose risk, it increased receptive syringe sharing, food insecurity, it reduced your odds of being in substance use treatment, and so on. And so in the current study, we've been able to drill down a little bit more detail into some of these issues. And so I'll sort of describe this to you. So, we have 429 people in Denver, Los Angeles, and Denver, for our purposes, have unfortunately very similar policies regarding the unhoused, particularly during this period. And so people frequently found themselves both unable to be housed, so only 16% were housed. And then there were the rest, so 84% were unhoused. And then among them, we broke them up into these groups. So there's a group that was unhoused but able to stay in the same location. So that was 22%. And then we had basically these moved once, moved less than monthly, moved less than weekly, moved weekly, which is sort of how you would interpret those other categories. And you can see the plurality of people are in that group that's been moved frequently. All right. So when you look at the sort of, for want of a better term, dose response of misery, you see, pretty strong signal. So generally speaking, for all of these measures, the more you move, the worse off you are in a pretty consistent way. And that includes both the sort of overdose risk and receptive syringe sharing, but then also the subsistence items like clothing, food, being able to wash, and access to restrooms. You're also at much greater risk of violence. And so again, you see that same relationship for the most part with people getting threatened, being punched, having their belongings stolen, being attacked by strangers. And then of course you see this other issue where, none of the people who were housed had been subject to sexual coercion in the last 3 months. And whereas it was much higher for the groups that had been displaced. So, profound physical insecurity, which just makes it very difficult for people to be able to take care of themselves. And then, of course, when these sweeps happen, people have things thrown away. So, over 90% reported losing clothing, 76% reported losing food, 70% reported having syringes thrown away, shelters thrown away in the 60% range. Naloxone, which is the medication that reduces overdoses, thrown away. Over 50% had that. Of course, losing your ID, having that taken away is problematic for receiving services subsequently. And then over 20% reported having buprenorphine, which is a medication, longer acting medication for opiate use disorder, being thrown away. So, folks are under assault. It's at the instigation of, the house population for the most part. So we looked at what are some of the sort of health and demographic factors associated with being displaced more frequently. And in this model, if you had been displaced at all, I just combined them all into one group just to facilitate being able to present the data. And as you can see, basically being younger increased your odds of being displaced, having a mental health disorder, being an opiate it's an opiate withdrawal symptoms, and then a hospitalization, and then having people be in substance use treatment was actually protective. All right, and so we wanted to look a little bit at then the relationship between these sort of displacement behaviors and the subsistence items. So again, using that Gelberg, I excluded the item on shelters and then just sort of added up the score, with the higher score being more difficult. And what you see here again is when you look at the scores across these different conditions, being displaced is significantly higher, both as a combined group and then even when you look at it by the breakdown. So the move 1 to 3 versus 14 to 14 more. And these are significant differences. So you have a strong signal. So you have an intervention, which is homelessness encampment sweeps, that both if it happens at all, and then as it happens more, you see a further diminution in well-being in the population. All right, so we looked at whether these displacements were associated then with sort of important health outcomes. And what you see here is, essentially it increases the risk. Any displacement increases the risk for non-fatal overdose, as well as being unhoused and then being displaced increases the risk for receptive syringe sharing. So we're creating the conditions whereby an HIV outbreak could happen in a place like Los Angeles and Denver by this sort of policy of harassing unhoused people who use drugs. And then this is work that Jesse completed and presented at the American Public Health Association meeting, just looking at the relationship between subsistence, those 5 things: food, shelter, clothing, restrooms, and showers, with non-fatal overdose. And you see that same relationship. And it's worth pointing out here, and unfortunately, we stopped talking about this in the 90s, but the amount of economic support that's provided to these populations is quite low. So essentially, general relief is the main vehicle that people get money, and that the amount of money hasn't increased in 20 years. And so you have people, really struggling with basic needs, and then that, of course, makes them more vulnerable to HIV and overdose death. All right. So I hope I've convinced you that this policy of sweeping homeless encampments, basically is an existential threat to this population, and is sort of at odds with our desire to see them housed and taken care of. It facilitates increases in their health risk, it's basically something that comes out of our political system. So we don't have to be doing this. We're making a choice to do it, and it's having devastating impacts on this population. Okay, so let me talk about these sort of changing drug use patterns, where I have less certainty of what it all means. Just full disclosure. So I'll talk a little bit about changes that happened between 2011 and 2018, and then I'll sort of look at what's going on now and try and sort of extract some information about what it might mean for HIV going forward. And we've written a couple of papers about sort of the dynamics that have happened with this sort of 4-wave drug use, change in drug use that we've observed in the United States. For me, the key take homes are, on one hand, a lot more people are using opiates now than obviously ever had in my life. The other point I would make is, and we have a paper on this, that when people move into the opiate use, that it really does increase their chances of becoming injection drug use, at least up until very recently. And I'll explain why that might have changed recently. And that, it's important to recognize that polysubstance use has sort of been common the whole time. But we do have some novel trends, I think, emerging more recently. So this is just comparing the 2011 data to the 2016, 2017 data. And so reflecting that sort of change in opiate availability, we saw some increases in sort of the percentage of folks who are white, big increases in the cohorts that are younger and that have been using drugs less long, for shorter periods of time. And I think, that sort of follows from the opiate prescription uptake that happened the previous 20 years. We're also seeing increased frequency of heroin use or opiate use. And this is sort of before fentanyl really hit Los Angeles and San Francisco. We did ask questions about fentanyl, and I'll show that to you in a minute. But we did observe this sort of increased intensity heroin use. And, I'm not quite sure what that was about. It could just have been the natural trajectory of use with a sort of younger group of people entering opiate use. But we also saw changes in methamphetamine use. So big increases in injection goofball use, and I'll come back to why that matters later, but that could be the sort of one of the big stories. And that goofball is basically when you combine an opiate. Historically, it would be heroin and methamphetamine, and now I think it's increasingly fentanyl and methamphetamine. So that sort of had been happening over time, and that could also reflect generational differences and sort of preferences for drugs with this sort of younger cohort entering the sort of world of injection drug use. We've also seen increased speedball use, and that's just sort of heroin or fentanyl combined with cocaine. And then we began, so this was at the end in 2018 of that previous study, we began asking about whether people have been exposed to fentanyl. Obviously, fentanyl, just we go back, beginning in 2013, and particularly on the East Coast, was contributing to a lot of overdose deaths. And it's been slower to hit the West Coast. It's here now, probably really hit in 2019, 2020, based on the data that I have. All right, so early on, we looked at whether people who reported being exposed to fentanyl had different drug use patterns, and we found they did. So basically, if you were using any illicit fentanyl, you were more likely to be a high-frequency opiate user, also to inject more frequently, and also to share syringes. And the reason behind that is fentanyl, as compared to heroin, is, while it is more potent, it is also shorter acting. And so that's why we would see more frequent use. And then, of course, people share syringes because they run out of syringes, generally speaking. And so if you're having an uptick in your frequency of injection, that will reduce the odds that you have a syringe available to you, even in the context where the programs, certainly in San Francisco and also in Los Angeles, not all of them are need-based in Los Angeles. Most of them in San Francisco are, but many of them are very close. So, people, take years that people began transitioning into fentanyl smoking. And so this is a paper that was led by Alex Kroll, based on data just in San Francisco. And I just pulled out one of the tables just to show in their sample the number of times people injected the last 30 days. And basically, this table just shows that it was basically from the July-December 2018 group onward, there was a consistent decline in frequency injection in this population. And, the idea is that that was because people began smoking fentanyl more. And, that can have important health risk. And in fact, there was some qualitative data collected as part of the study. And one of the observations where people were reporting that once folks began to learn how to smoke fentanyl, it has some advantages. So you're obviously reducing your risk of infectious disease spread because you're not puncturing your arms. And if you've been using drugs for a long time, you don't get the stigmata related to track marks. And you don't have to bother with this sort of getting syringes, which are sort of a little bit more problematic, even though they're readily available in San Francisco. And so basically people are smoking. So if there are pipes available, they'll smoke with a pipe. In Los Angeles, I've seen people both using pipes, but also just the good old-fashioned chasing the dragon, where they put the sort of heroin on a tinfoil and then heat it, and then inhale the vapors as it sort of burns off. There's an example of this in Bad Lieutenant, if you want to go back and watch that Harvey Keitel movie, which is, it couldn't be more depressing. But he, at one point, does some chasing the dragon, so you can see it in cinematically represented. Okay, so as a consequence of knowing that fentanyl was coming in, we began asking fentanyl-specific questions in our new study when we started in 2021. And so the trends that we've picked up, and what I've done here is just sort of broken my sample up into 6-month cohorts, for want of a better term, and just reporting what people are using at each sort of cohort. So the first 6 months, second 6 months, third 6 months. So that's what that represents. So the blue is the first 6 months, and the gray is the last 6 months. And you see there's been a significant decline in imported heroin use, a significant increase in fentanyl use, also an increase in crack cocaine use. And then we looked to look at daily patterns of drug use. And all these data were collected for the last 3 months. So we just wanted to see if daily patterns were changing. And that's a big deal, particularly when people are using opiates, because you have to prevent withdrawal. And so people are often going to be daily users. And so we're seeing a real reduction in reported daily injection, and an increase in non-injection drug use methods, increase in daily fentanyl smoking, and then you see these declines in heroin use in general. And so, essentially in Los Angeles, in most neighborhoods now, heroin is hard to find and fentanyl is easy to find. All right, so we tried to look at these in relationship to some health risks. Doesn't appear to be a signal related to overdose or receptor syringe sharing, although theoretically, over time, if these trends can continue, I would expect that we would see some improvements in both receptor syringe sharing and also overdose. And part of it is because, and this is, I've observed this myself in the field, the way people are smoking fentanyl is not everyone, but some of them are sort of moving into this sort of frequent fentanyl smoking, which is, I think, much safer. So what'll basically happen is they'll have their foil or their pipe, and they'll just take a hit every 15 minutes or every 20 minutes. So that'll keep them from having withdrawal symptoms. They don't get particularly high, so they're not vulnerable to violence. And it's sort of a maintenance dose almost of fentanyl. And so that's probably the best case scenario in terms of reducing both the injection-related HIV risk and then some of the other risks that happens from when people are using opiates regularly. And we have this slight decline in opiate withdrawal. Again, we'll see if that plays out. So if the sort of frequent small dosing or micro dosing of fentanyl takes off, maybe we'll see some real returns in terms of reduced opiate withdrawal reports. We did have this sort of signal for abscesses, and so we created a multivariate model to just look at whether this sort of secular trend was associated with decline in self-reported abscesses. And it was, at least in the sort of first period of October, March 2021-22. Fortunately, we have a smaller sample in that April to November 22. But I think that actually is a sort of indication of the continuing trend. We were in Skid Row in the fall of last year, and really had a hard time recruiting people who are injecting drugs. So people still inject drugs there, but it's definitely, they've become a lot harder to find than they used to be. And so these are the things that we control for. All right, and now polysubstance use, which I have even less confidence in terms of what I have to say about that. But let me just start with a few overall comments. So the first is, of course, people have always used multiple substances, and if we consider alcohol and nicotine as mind-altering substances, then everyone is a polysubstance user in these studies. So that's just something to keep in mind. There are different kinds of polysubstance use. So when you combine them together, like with the speedball or goofball, when you use them concurrently, like on the same day or sequentially. So there are definitely reports, anecdotal, talking to folks who say use meth, and then they might use fentanyl at the end of a run to sort of help with the sort of physical discomfort that comes from abruptly stopping meth use, or vice versa. So you could have people who are mostly using fentanyl, but they might inject methamphetamine in the evening so they can stay awake at night and sort of protect themselves from violence. And at the end of the day, I don't know that we have a great handle on how to both look at these things and look at these sort of different kinds of patterns of use. I certainly haven't figured out an efficient way to do it. If you have, I'd be happy to learn about that. And then we have the limitations in our current study. Because we asked about drug use over the sort of 3-month period, we have decent data on the combined ones that we ask about, so speedballs and goofballs. And then what I did was I just looked at patterns of daily substance use, which is would be that sort of either concurrent or sequential use pattern, which I guess just to me felt like a more reasonable way of thinking about polysubstance use in these populations. And so we didn't find a ton, So, basically it looks like goofball use is associated, and for sure, the multivariate model I presented earlier on receptor strength sharing, one of the covariates is goofball use. So goofball use definitely is contributing to increased receptor strength sharing. I'm not sure why that is, so that's something to investigate. It also increases the odds of non-fatal or reported non-fatal overdose. And then we looked at a couple of sex variables. So paying sex partners, so folks who were reporting daily injection of more than one drug were more likely to be sex workers. And that might just be because of the more intense drug use pattern, but there's more to learn there. And then we'll also in the future look at reports of condom use. And the pattern in this population, is pretty similar, I think, to other populations where you see folks who have a steady sex partner report very little condom use, and then it sort of increases with casual partners, and then with paying sex partners. It's not perfect, but there's a lot more condom use in the group that's involved in sex work. All right, so just some summary thoughts. So, stimulant use is increasing. The impact of this on behaviors and health risks, I think, there's something going on, and certainly with goofballs, we probably need to do some qualitative research to figure that out. There is some promise in terms of reduced health risk if fentanyl smoking takes off, but I do want to indicate that there is a danger with that as well, which is, the truth is, smoking is easy to do. We have a new generation of youth who are coming up with vaping, and so it's pretty common among younger people. And so one danger of the fentanyl smoking is that it will be deemed more acceptable to young people, could lead to increased fentanyl use among sort of a cohort of people who's coming up now. So that's something to keep an eye out on and obviously prevention. There's a lot of messages about how dangerous fentanyl use is. And it certainly, we know from the overdose data in Los Angeles in particular, and California in general, many of our overdose deaths are now due to fentanyl use. And then if you have a naive population entering it, that also increases the probability of mortality. So there's some important work to do sort of at the intersection of non-injection fentanyl use and the overdose risk, and then the sort of HIV injection risk. And then, I think the jury's still out on the relationship to sex risk, but we'll keep looking at that data and figure out if we can figure something out. All right, so there are things that we can do about all of these problems. But I do want to just start with this observation. So, when I began doing this work in 1990, the big problems people had that we were asking questions about were obviously HIV and abscesses to a lesser extent. And overdose wasn't a big problem back then, although obviously people were dying from overdoses then as well. But that's obviously become a big issue, top of mind. We also have, a national epidemic in hepatitis C, and, the sort of two hump Campbell version now of hepatitis C, which used to be one hump. So that's something we need to attend to. And then we do have strong indicators that bacterial infections are growing rapidly in the country. And in fact, we just submitted a paper to MERS looking at what we're seeing in goal around hepatitis C. I'm going to stop for a second because my internet connection has become unstable. All right, I think it's back up. All right, so, we have these goals about how to prevent HIV, and the truth is we're basically not getting there where it regards people who inject drugs. So only Seattle was close to the consensus level of giving out enough syringes. No one was close in terms of getting medication for opiate use disorder out to enough people. And of course, PrEP has been not very successful, right? So we just published a paper that Susie Walters first authored looking at our data. And there's great awareness of PrEP and HIV PrEP, and even willingness to take it, but only 2% of people have actually gotten it. So a lot of work to do in terms of helping people. All right, so what we could do is obviously fully fund syringe service programs, begin pipe distribution, and of course, there was that unfortunate thing that happened, I believe in 2021, where basically Department of HHS came out and said they weren't going to fund pipe distribution. We should continue to struggle to get safe consumption sites implemented. And then we should think about safe supply, both for opiates and also stimulant use. And there's some trials going on showing, really positive outcomes and improvement in people's health if they have safe and ready access to pharmaceutically produced drugs. I think the other thing is we need to, really take on these sort of popular policies that undermine well-being of people who use drugs, like the homeless camp of Sweet Mints, continue to push for decriminalization of illicit use, and then continue to invest in communities. So in LA County, we're fortunate we have this Measure J that's slowly ramping up and beginning to put money into community prevention and treatment services. So we need more of that. And then, of course, we're all watching carefully the Oregon situation and the infusion of money into both treatment and harm reduction services that I'm pretty certain will have an important impact on people's well-being moving forward. In terms of research, we need to look more carefully, I think, at political and social determinants of health, because they do represent an existential threat to the health and well-being of people who use drugs. And then, of course, and I have a slide on this I didn't include in this talk, but continue to uplift the voices of people who are in these experiences. I'm very aware, and even more so as I get older, of the social distance and differences in social and economic circumstances between myself and the population I work with. And the truth is they've come up with most of the things that have worked. They came up with needle exchange programs. They came up with naloxone distribution. They came up with safe consumption sites. And so they do have the answers. We just need to find the political will to get the resources to support them. I've shared with the organizers of this talk a PDF of this, so you're welcome to have it. Just ask for them, and then these are the references I cited throughout the talk. And thank you for your attention. It's a pleasure to talk with you. Look forward to the question and answers.
Thank you.
Or as I like to say, the comments and complaints.
Thank you very much, Dr. Bluthenthal. We'll entertain some questions now. And you can either put them in the chat or raise your hand. Dr. Gorpach, I see your hand.
Oh, I can't hear you, Pamina. We still can't hear you. It looks like Steve has a question.
There should be a unmute on your screen. Go ahead and unmute.
Okay, now I'm unmute. Can you hear me now? Okay, so thanks. Always such a pleasure to hear from you, Ricky. So thanks for taking your time to do this. And I always hear you talk and have 1,000 questions. So a couple of the ones that I want to ask you about are twofold. One of them has to do with the polysubstance use, and some of the substances like cannabis and alcohol that weren't in sort of your analysis, and wanted you to sort of talk about, particularly cannabis with, some of the methamphetamine and stimulants, and, your sort of thoughts on that. And then the other one is, I'm going to want you to say something about what you think about these machines that we have, the drug checking machines that I think we have a pilot going at the LGBT Center with Syringe Exchange now. And I know you have opinions. So I'd love for you to share your thoughts on the potential for this as a harm reduction strategy and how you think we can use that. So
just say the last thing again, because we lost you. I didn't hear you. After the harm reduction, right before the harm reduction thing.
Oh, so I'd love you to tell us your thoughts about the use of the drug checking machines.
Oh, right. Okay, great.
Which I think we have a pilot going with syringe exchange at LGBT Center, but just your thoughts on how and if. I know you have thoughts. So.
I do. All right, so let me talk about I can deal with the cannabis methamphetamine opiate thing quickly. So, I mean, there are reasons to think there's something going on between those three drugs. Both, preclinical and, self-reports. Certainly people report using cannabis to deal with withdrawal and to lessen opiate use. And we have that data. So we just haven't looked at it yet. So hopefully I'll be on sabbatic next year. And so I'll spend a lot of time looking at that. And then the same thing is true with methamphetamine. So there's they don't, I'm trying to remember because we've looked at this a little bit, and I feel like the people who use methamphetamine were less likely to use cannabis, and I'm not sure why that was, but I might be misremembering that. So stay tuned, and I'll get the right answer when we look at it. And then in terms of drug teching, I mean, there's nothing wrong with drug teching. There's just nothing right with it either. So, it is the kind of thing where if people have less chaotic lifestyles, you can certainly use it. And I won't disclose, but I've talked to young people, for instance, who are using other drugs like ketamine and cocaine, and who are well-resourced, who talk about using those technologies to protect them. And of course, the work that Dan Stafe has done for decades. That's all good. And I think it works well with those populations. It's a little bit harder for the unhoused population because there's details, right? So, the fentanyl test strips don't capture all of the analogs that are sort of out there. And, it's difficult to make sure you got, because the fentanyl is still being sold in the sort of black tar version here, that gummy, it's hard to sort of make sure you've tested the whole thing, but there's nothing wrong with it. So I don't think people should not do it. I'm just not certain that, but I think it can be helpful for drug use epidemiology. I'm not sure that it's helpful, for the most at-risk people. So I think that's my view.
Dr. Chaptal, you had a question?
Great. Dr. Bluthenthal, that was fantastic. So thank you for doing this. I have a couple questions. One is, there is this harm reduction thought that by moving to pipes for fentanyl, that it's safer than injecting. It's very quick to get to the bloodstream through the lungs. So the question is, I mean, your data didn't convince me that there's a big saving in terms of non-fatal overdose by using this route. So what do you think? So these are database questions. What do you think about the harm reduction message that smoking is safer than injecting? And related to the data-based stuff, can you talk a little bit about, this is a two-parter and this is completely different, but that first part of your presentation was fantastic. How is that data being used to deliver care in LA? I could see a real clear way that the health department or health services could use that data to stratify some differing kinds of interventions for people who are out there who have different levels of being moved and housed. So
yeah, well, I mean, I think so. I'll do the last first. So I've given versions of this talk, I think all over the country at this point. Probably could reaching out to the local health authorities. I mean, I do have some connections with Karen Bass, and I'm hoping to talk to them soon and share this information. But I think the basic takeaway was sweeps are a bad idea. And then in terms of the pipes, I mean, we're adults. Everything is bittersweet. So the data isn't in yet that supports that pipes will stop overdose deaths for sure. We don't know that. And, the data I presented, it looked like there was a signal related to abscesses, but that was only secular. So if I looked at it more directly about who's actually smoking fentanyl, there's no difference. We shouldn't be over enthusiastic. And then I think the third part is that, smoking is easier to do. And we do now have a cohort of young people who have been vaping. So, moving to fentanyl will be easier for them to do than prior generations. So, so there's no silver bullets, obviously. For older people, who have been injecting heroin for a long time, smoking fentanyl frequently. It seems like it really works, but that could be a very small group of people. So I think there are definitely unsure benefits and some real potential dangers that we need to track. And, you know, I mean, at the end of the day, you and I will agree we should, I mean, I'd love to be in a world where it was like buprenorphine was as readily, and methadone were as readily available as fentanyl is. That's my Valhalla. That's, you know, and we have a lot of work to get there.
Right,
Yeah, Gregory, you had a question? Did you want to go to him?
Yeah, thank you very much, Dr. Bluthenthal. My question is regarding recruitment and retention. I heard two different things. One was community recruitment and one was targeted recruitment. Can you share with us those type of two recruitments that you did with this target population?
Yeah, so you know, typically we will do targeted sampling. So we'll sort of map out the communities that we want to be in and, you know, identify, and you've done that in LA. I mean, we've collected data all over Los Angeles from Long Beach to Antelope Valley. We just didn't do that this time. And, you know, we didn't with COVID. So that's why I changed the term. So, because that's not what happened. So really we went in Denver, we collected data from that harm reduction center, which is a great place. And that's the only place we collected data from. And then in Los Angeles, we collected data from the Refresh Center in downtown, from from the park in East LA, because we have we know enough about the drug users in our local community to be able to do that. And then from the needle exchange at the Gay Lesbian Center. So, you know, we can't pretend like this is a representative sample of Los Angeles. So
thank you very much.
There's a couple questions in the chat for you, Dr. Bluthenthal. The first one is from Nathan Earl. Did you see any strong associations between commercialized violence, either labor and sex, and housing insecurity, polysubstance use, and or IV in your studies?
Yeah, so we have a paper actually about sexual coercion from I think it's from the 2016 study. So it's widespread. And housing insecurity is related to it. So, you know, there's that one slide. Basically, if you were housed, you didn't get raped in the last 3 months, and if you weren't housed, you know, 10% of you did. So, and of course, that's almost all women. Although, you know, we do have a paper. It's really women and men who have sex with men. So, you know, about 10% of women have been raped in the last 3 months, and about 9%. We have a small sample of men who have sex with men have been raped in the last 6 months. So, you know, these things are real problems for those populations and people who use drugs. But it's not related to the drug use. It's, I think, in the direct way. It's more related to. Well, I shouldn't say that. It probably is related to both. You know, there's a paper that hasn't gotten enough attention. By a guy, Pedro Gelbert. I always get his last name wrong, but he did a qualitative paper with young prescription opiate misusers like 7 or 8 years ago. And the men were reporting like getting women high on opiates so that they could rape them. Like, so that kind of stuff is happening. And then, you know, we know there was the case of that movie producer in Hollywood. So yeah, I mean, I think there's a lot of violence and a lot of sexual violence, and being unhoused and high contribute to that in this population. It's a real tragedy, and I'm hopeful that people will begin trying to intervene more directly on those issues.
The next question is from Emily Furman. Thank you, Dr. Bluthenthal. What are your thoughts on the recent expansion, clarification of Medi-Cal guidelines to reimburse providers practicing street medicine? How much potential do you think this has to increase access to harm reduction services in unhoused, housing insecure populations in California?
You know, I think it's huge. You know, I know there are now, you know, growing proliferation of street medicine teams in Los Angeles, which I think I welcome. You know, and one of the things that's important, and I know the Britt Feldman and Corinne and USC, you know, is that human connection, right? like they're, approaching people in a loving and helpful manner and dealing with their most pressing needs immediately. And that's what this population needs. So, one of my criticisms of, even as I've learned of, even how we try to house people is, all of this categorical funding, and, you got to get this, go to this pot to get the furniture money, and this pot to get the clothing money, and this pot to get the transportation. It just creates this, Kafkaesque labyrinth of rules and regulations that get in the way of helping people who have really profound needs. And street medicine is a great way because they also can cut through a lot of that bureaucracy. And I'll just brag about them a little bit real quickly. They had a hospitalization service in the county hospital for a couple of years. And, they did a great job of getting people housed, right? So they would identify the unhoused people who were in the hospital. And, with the people who had contact with street medicine, 80% of them were walking out of the hospital and into a house. Or a rehabilitation hospital. And for the people who weren't having contact with them, it was like 20%. So they're really a big part of the solution, I think. But, it's part of it's the principles they operate on, which is let me help you right now with the thing that's important to you. And we have too much of a what's important to us. Or like this ridiculous, we don't want to waste money, or is this effective? I mean, it's like, look, we have a social economic system that generates human misery, right? Frederick Engels would call it social murder. It's happening in front of us every day, and we need to stop doing it. And so things like street medicine are one way to stop doing that. And thank you for coming to my TED Talk.
Thank you very much. It looks like we have time for maybe one or two more questions. Are there any more questions from the group?
Hi, it's Judy Courier. I just want to thank you, and I'm just so encouraged to hear that you have connections with Mayor Bass. Just would love to hear what your thoughts are about the potential for really changing the housing options and services in LA. Are you optimistic? You just have so much experience with this. Want to end on a positive note.
Yeah. I mean, I think she's trying, right? So, I mean, I think what they've tried to identify, and I want to say hi, Michael Murley. Great seeing you, man, after all these years. There's a bunch of you, and Michael Lee. Right, there's a bunch of Michaels on this that I've known for years. So it's great seeing you all. Yeah, I mean, I think they're trying to identify this motel situation and put people immediately into that who are willing to go. But I do think, so let me put out two ideas. So one is patience. And, that is not what our political system is designed for, right? I mean, we basically live in a country where one political party is just setting people's hair on fire every day, as like, that's how they get support. So we need patience. And then there are other models like the Trieste model. I don't know if you're familiar with that. I'm hopeful that we're going to have a presentation on that at USC in psychiatry either this spring or summer. And basically what the Trieste model does is it just assigns $7,000, $8,000, $9,000, $10,000 to a patient. And then working with their case manager, they can use it however they want to get better, basically. And so that gives people the kinds of flexibility, and I know I'm going over, but I'll just say there's a case management program I've had a chance to observe, where they go the extra mile. So there was a case where there was a transgendered woman who was in a residential treatment facility. It had to be closed down. And he was able to hang out with her for the weekend, get her reconnected with her mom, go down, spend some time at the beach, stay in a hotel for a couple of days, and then get her back into a residential treatment facility on Monday that suited her needs. And that's what we need. Like we just need to do that, 60,000 times, right? And be flexible and patient and recognize these folks are under assault by us. It's us. We're doing it to them. And we need to stop and give them the resources they need to take care of themselves. I hope that was positive.
Well, thank you everyone for attending, and thank you, Dr. Bluthenthal, for a wonderful talk today. I'd like to ask everyone to please complete the evaluation in the chat. This recording will also be available and sent via email. So again, thank you very much, everyone, for joining us. Thank you, Dr. Bluthenthal, for again joining our CFAR CHIPS Grand Rounds.
Our pleasure. Take care, everybody.
Bye, Ricky. Great talk.